Can everybody hear me? Okay, great. Hi, I'm Jessie Golbus. It is truly my pleasure to be here today to talk to you about the use of digital technologies in cardiac rehabilitation. Now, many of these comments are based on an AHA advisory that we recently published and that I was privileged to be a part of. Now, this advisory thought about some of the gaps in the field of cardiac rehabilitation and laid out our vision for how we saw digital technologies in cardiac rehabilitation being used. And so I'm so excited about this panel that is going to come up on stage after me and is going to be talking about work that they're doing to advance the field, as this is a group that has thought deeply about the intersection of digital technologies and cardiac rehabilitation. So displayed in front of you is a figure that shows how digital technology can intersect with cardiac rehabilitation in all of its different modalities. So as you all know, currently cardiac rehabilitation is delivered predominantly as center-based, in-person cardiac rehabilitation. But there's the ability to deliver cardiac rehabilitation using synchronous real-time audio-visual or virtual cardiac rehab, or asynchronously, also called remote cardiac rehabilitation. And you can envision that the digital technologies will be used differently in each of these forms of cardiac rehabilitation. Now, our group thought a lot about opportunities for refining the delivery of cardiac rehabilitation. The emergence of smart wearable devices in cardiovascular care offers a true opportunity to refine biometrics and to focus on objective monitoring of goals such as increases in physical activity. Traditionally, cardiac rehabilitation is focused on biometrics and hemodynamics, but we really see digital technologies as an opportunity to expand that focus to factors such as sleep, socialization, and mental health. There's also the opportunity to use these digital tools to allow for greater caregiver and social support integration and personalization of training plans through things like artificial intelligence. Now, our advisory also thought deeply about some of the gaps in the field of digital technologies and cardiac rehabilitation, and we focused both on clinical gaps but also on methodologic gaps. So as the research starts to emerge, we really see a need for studies in community-based practice settings, expanding beyond the traditional academic medical centers. There also need to be studies with extended follow-up beyond the traditional 3 to 6 month delivery period. And we need improved diversity, both with respect to socio-demographic characteristics, but also the inclusion of additional populations, such as those with higher risk conditions like heart failure and adult congenital heart disease. We also see the need for studies looking at more complete management of comorbidities. To date, many of the digital tools in cardiac rehabilitation have focused predominantly on increasing physical activity. In addition to these clinical gaps, we've identified a number of methodologic gaps that need to be addressed. And I've highlighted here for you 4 that I think are important. So first, we need robust digital data from diverse patient populations to understand risk. I think right now we still struggle to interpret the data that we get. And to give you a very objective example of what I mean by that, what change in step count is clinically significant and actionable? And does that differ if somebody has heart failure as opposed to coronary disease? We also need to improve our selection of patient-specific digital solutions. I envision a world in which the digital tool may be different for a 40-year-old who had a PCI as opposed to an 80-year-old with multimorbidity, frailty, and poor eyesight. We also need automated interpretation and integration of diverse data streams. Currently, we focus predominantly on one data stream, and there's no integration of these diverse data sets to better understand patient risk. And finally, I think that there needs to be clear delineation of responsibility for digital data review. I think that's really important both for preserving clinician quality of life in an era of burgeoning digital data, but also for patients, for understanding when their data is reviewed and by whom. Now, my last slide here touches on the importance of equity-centered digital health in cardiac rehabilitation. And this is such an important topic that I'm going to defer an in-depth discussion to many of our panelists who have thought very deeply about the role of equity in digital health. But I think that we all are aware here that while digital health has the opportunity to break down barriers, it also may paradoxically exacerbate health disparities. And so I think it needs to be implemented thoughtfully and throughout the life cycle of cardiac rehabilitation. So with that, it is my true pleasure to introduce our panel today. So our moderator will be Dr. Seth Martin. He's a close collaborator, a professor of medicine in the Division of Cardiology at Johns Hopkins University, and a member of the Health Tech Advisory Group. Our panel will include Dr. Dan Foreman, a cardiologist and professor of medicine at the University of Pittsburgh, Dr. Anna Barak, a cardiologist and specialist in cardio-oncology at Inova Health System, Dr. Erica Shore, an associate professor and chair of Adult and Gerontological Health Cooperative at the University of Minnesota, Dr. Marta Supervia, an associate professor and cardiac rehabilitation physician, Dr. Francisco Lopez Jimenez, chair of the Division of Preventive Cardiology in the Department of Cardiovascular Medicine at Mayo Clinic. We'll also have an innovation showcase, which will include Dr. Asif Ali, a cardiologist at the University of Texas Health Science Center in Houston and a member of the Health Tech Advisory Group, Dr. Francoise Marvel, cardiologist at Johns Hopkins University and co-founder of Corey Health, Dr. Alexis Beatty, a cardiologist and associate professor of epidemiology and biostatistics and the lead of the CHTI Advisory Group on Digital Cardiac Rehabilitation. And finally, Dr. Yedrick Wozik, cardiologist and leader of clinical strategy at Samsung Health. So with that, I'd like to welcome our panel and moderator up to the stage.
Well, thank you, Jesse, for those fantastic overview. Thank you for leading that important science advisory from HA. Thanks as well to Pat Dunn, who was part of that science advisory. Kudos again to Pat and the whole CHTI team for this great innovation pavilion. I think for the panel discussion, we'll probably start on the topic of equity. I wanted to first say that when we thought about digital cardiac rehab as a science advisory, we're very clear that this is to augment existing cardiac rehab. We're not trying to replace, but to augment it and increase access to many groups, such as underrepresented minority groups, older adults, women who have traditionally lacked access to cardiac rehab. And with that in mind, building the bridge for these types of patients, I want to start on the topic of equity. I know many of our panelists are passionate about viewing cardiac rehab through an equity-first lens. And so I think I may come to you first, Marta, if you could give us your perspective. Marta actually brings a very unique perspective coming from Spain, bringing an international perspective, and we're going to pick her brain a little bit over the course of the panel on the differences between Spain, a public health system, and our experiences in the US. But I first want to focus in on equity, kind of hear about how you're thinking about that and how we can make sure that what we do in digital cardiac rehab really builds bridges for our patients and increases access.
So, thank you. So because I am in physical medicine and rehab, so when I talk about equity, I think besides ethnicity, I think in people with disabled diseases. So I usually see a lot of patients with, for example, multiple sclerosis, spinal cord injury, that they are not engaged to the usual cardiac rehabilitation program. And I think that digital tools could be a good opportunity to reach them because of the barriers that they can suffer to come to the center and so on. So from my point of view, in order to develop appropriate digital tools for those kind of patients with disability, maybe we think we have to study like the pathway of the patient and to see all the barriers and to see how to address those specific barriers for those disabled people. And
Thank you. Erica, I wanted to see if you want to add in on this opening topic of equity.
Yeah, so this was something that we identified as a challenge in our scientific statement a couple years ago on mHealth for secondary CVD prevention. I think that Marta brings up a really good point in following the patient all the way through their journey. And that includes involving them in the development of the technology that we're using so that we can identify some of those challenges and for each patient, right? It's an individualized approach. And so somebody who has a spinal cord injury is going to have a different challenge than somebody who doesn't have any other medical conditions or comorbidities. So meeting the patient where they're at and providing individualized experience is really essential.
Great. And I'd like to give a shout out to Dr. La Princess Brewer, who's in the audience, who's taken that very approach in her work with the FAITH program, bringing community members in, building from the ground up to really build a solution that best meets the needs of the end users. And I think with respect to the development of technologies to support digital cardiac rehab with an equity first lens in mind, Francisco, I wonder if I could come to you. I know you're passionate about making sure that the development of technologies to support digital cardiac rehab really has the interests of the patients and clinicians in mind, and making sure that we kind of best align with the tech world and engineers in that respect. So would you care to weigh in on that topic?
Yeah, definitely. Those who are thinking about developing tools to be implemented in cardiac rehabilitation need to really have stakeholders involved in the process, all the way from the conception, the design, the deployment, and the validation. And to have not just the patient's perspective, but also the users. And the users includes physicians, technicians, advanced practitioners. Everybody who is part of cardiac rehabilitation need to be part of that process. A problem we have seen is that there are many solutions for problems we don't have, and no solutions for major problems we do have. And perhaps the way to bridge scientists and computer scientists and technology and clinicians is by reaching out to each other to better understand what we need, and for us to understand the potential they have to resolve our problems. I have said this multiple times that my role at Mayo Clinic, that is another hottest co-director of AI in cardiology, is actually a very simple one, which is the translator between the engineers and the clinicians, so we can understand the full potential they have to fix solutions that we might consider unfixable.
I'd like to weigh in with the perspective of an aging population. To me, this is a driving passion in terms of cardiac rehab and the healthcare delivery in general. But as we talk about technology and digital applications, I think many people start with a preconception of it being new, of being very compelling from the perspective of younger populations, seeing this as a novel extension of the existing delivery of care. But I think for our patients, that could be a little bit intimidating. So when we talk about equity, I would, as you said, having the engineers and having all the developers think about the perspectives of the patient, where the patient's coming from. But I want to really remind us that the patient is often impaired. The patient may not have visual acuity, may not have hearing, may not feel comfortable with technology. So to me, the most accessible technology is the old telephone, which anyone could pick up and use, whereas a new smartphone may be a little bit less accessible, and many other wearables may be less accessible. So as we think about digital health, in many cases, it may be the most simple device possible, not the new glitzy one.
Right. You bring up a number of good points, Dan, and part of this is you've taught our group about, these intrinsic factors that are barriers for patients, whether it's, frailty or, visual impairment that could preclude interactions with digital devices. But then there's external barriers that keep people from cardiac rehab, whether that's costs, transportation, so forth. Dan, do you want to speak a bit more about kind of how you've overcome some of those barriers in your cardiac rehab program? I mean, I recently just had the personal experience of a patient who was really excited to participate in our clinical trial, which is testing a digital home-based cardiac rehab program versus traditional program. However, he has Parkinson's with tremors, and he was viewed as a high fall risk, and given the kind of eligibility for our trial, unfortunately didn't meet that. I was very disappointed, as was he. But that's one example, someone with tremors and is viewed as a high fall risk that could preclude a home-based approach. Do you want to speak about, you deal with many patients with other, intrinsic factors that preclude cardiac rehab. How are you overcoming these?
Yeah, well, I don't think I've overcome them all, but I think highlighting the issues is really the first start. I mean, again, this is like my soapbox in terms of saying that 1 out of 4 Americans is going to soon be over 65 within all of your careers, and that the population of 85 and over is the most rapidly growing demographic in the world. And these are the people who are most likely to have cardiac disease, and these are the people that are most likely to have sarcopenia and frailty, and everything that really, in a sense, confounds evidence-based care. So while we all think we're such clever caregivers for cardiac patients, I think right now we're kind of striking out for many older adults. I think cardiac rehab is resilience 101. This is the most important therapy we can administer to our older patients. It is vital. It is the most important thing in combination with everything else we might think of. So, yeah, there are all kinds of impediments, as you've said, barriers to care, fears of falling or risk from exercise itself, barriers to get to the site, to a cardiac rehab facility. On every level, people think of barriers first, but I would really emphasize the vitality of it is, and the benefits are disproportionate. So sometimes there's kind of a reasonable risk of trying to think about cardiac rehab, and the new models of care that we've discussed or are beginning to discuss about home-based models, wearables, I think present opportunities. Exercise can start with seated exercises. They can, to mitigate some of the risks that might be associated with upright exercises. Things can start with a slower, with less intense modality and build up in frequency over time rather than intensity. So there are strategies to really reduce some of the risks that emphasize incremental benefits over time and not really trying to have the exact same standards or trajectory that you might think of for younger adults.
Great, thanks, Dan. Anna, I wonder if we may turn to you to build on this. Anna brings a unique perspective from the world of cardio-oncology, and some of your patients are going to be older as well, as Dan's are. Curious if you could share some of your experience with overcoming barriers.
Absolutely. It is, I like to take a look at it from, I think of the indications from cardiac rehab as a first, what I view today has almost become the barrier for a lot of my patients because we have evolved so much in understanding the disease. And this conference is full of presentations of understanding of cardiometabolic components of the cardiac disease, honestly, of what leads to heart failure with preserved ejection fraction. And the reason why I'm passionate about cardio-oncology population, if I think of a patient with breast cancer, it's 1 in 8 women. If I think of a patient with prostate cancer, like we just add on additional layer of mental health, of another barrier of a person needing to go to the doctors many times. And then I look at the indications, how can I get that patient just through the door of cardiac rehab? And I find myself using shortness of breath as a stable angina indication for cardiac rehab. I think it's, of course, it helps me in that one patient, and I feel that we all can morally do that. I don't see a problem with that.
But I think as a group, we are all, and this is preaching to the choir, that I feel that we need to bring even the indications and the outcomes of cardiac rehab closer to the diseases that we understand so much better. So today, I think that there is, so specific to cardio-onc, we have awareness of how much physical exercise and structured physical exercise and the cardiac rehab components could improve, but having it as formal, it will allow us also the prospective testing and really opening the door for that population, because we know that it is a significant burden that tends to be added with the components of oncology therapy that, on the other hand, are driving incredible survivorship that we have never had before. And it's very, very similar in prostate cancer. I feel it's sometimes, and I look at you, Dan, because you always think of that's the demographics, right? Like we are seeing the increase in overall prevalence of prostate cancer because it's a disease we'll live with. The anti-androgen therapy is evolving, and there are ongoing trials, but you're seeing these very patients in whom hopefully they will never have an acute myocardial infarction to meet that indication for cardiac rehab. We have to learn earlier. So I got very interested in this tool because there's a lot of interest on oncology side as well. I really think we need new models where we could apply everything we've learned until now about cardiac rehab into new definitions, and then see how it really improves outcomes. We have been so successful in showing in those indications, but it's going to be even more powerful in the future.
Yeah, and so I'm glad that we've kind of turned attention to the kind of the early part of the patient journey, which is the referral to cardiac rehab. And there's opportunities for new indications for cardiac rehab, groups of patients with heart failure with the preserved ejection fraction, atrial fibrillation, other groups of patients that could potentially meet the indication, be referred in the future. Also, we currently struggle with the referral of patients that already meet criteria for cardiac rehab. And there's, one of the aspects of this conversation this afternoon we want to get into is some of the legislation that's in the works to try to help with this. I wonder if I might come to you, Francisco, to speak about legislation related to APPs being able to refer directly to cardiac rehab, but also just how you've approached referrals from an equity standpoint, because there is evidence that underrepresented minority groups are less likely to be referred to cardiac rehab. And so how at Mayo Clinic are you kind of approaching that, and what's your view on the upcoming legislation? Is that going to be helpful?
Sure. Let me start with the legislation that, first of all, there was one bill that was passed a year ago, and it's going to be implemented beginning in January 2024, that would allow APPs, or advanced practice providers, to staff cardiac rehabilitation programs. That was one, and that was a big win. And there is one bill right now that is being under review, and hopefully to pass in the next 6 months, that will allow APPs to prescribe cardiac rehabilitation. And the point we make is, well, APPs are allowed to prescribe very high-risk antiarrhythmics, but they are not allowed to prescribe cardiac rehabilitation. So that doesn't make any sense. Now, why is this important? Well, because a lot of the health systems rely on APPs in hospital settings to dismiss patients post-MI or post-CABG or other indications for cardiac rehab. So by empowering them to do that and simplifying the referral process, we might actually overcome some barriers. I can tell you what we did a few years ago at Mayo Clinic. The performance was about 50%, so only 50% of the patients were being referred to cardiac rehab. And we try many things, reminders and letters and emails and all those things. And you will improve by 2%, 3%. But it wasn't until we set a hard stop rule in the electronic medical record that, unless the patient is referred or you justify why the patient is not being referred, you cannot complete the dismissal process. So those are the tools that really can become really effective system-wide without relying on the human factor and personal beliefs or choices, etc. And we believe that it's also a way to reduce inequities, because those systems don't recognize socioeconomic status, race, or this and that. They just go for everyone. And I want just to say, and again, we are preaching to the convert, but to me, the lack of referral to cardiac rehabilitation and the fact that only 20% of Americans who need cardiac rehabilitation with approved indications get it is one of the biggest tragedies of modern medicine. I don't think there is another huge gap in what we know works and what we do, and cardiac rehabilitation is one of them. So I think digital health is an opportunity to really overcome that barrier, because we can make cardiac rehabilitation cheaper, more accessible, scale, and reach out to people who will otherwise be impossible to come to cardiac rehab.
So thanks, Francisco. And I think I'll circle back with you a little later about some of the other legislation in the works that's going to help support digital cardiac rehab and access to cardiac rehab. But I want to come back to you, Marta. We'll move on to the kind of further part of the patient journey in a moment. But with respect to referrals in Spain, what's it been like in Spain? Are you leveraging similar EHR tools where it's kind of a hard stop if you've got to refer to cardiac rehab? What have you found has been successful in Spain?
So the rates of referral in Spain are not so good. It's like across the world. But the thing is that in our country, at least we have public health system. So I think that besides the referral from the healthcare providers, one of the barriers is the lack of awareness among the patients that they have to go there because they think that the heart disease is fixed and so they don't need anything else. Because, for example, in rehab, if you have a knee surgery, you know that you have to go to rehab after that. But with the heart disease, most of patients, they don't know about that. So there is a movement in the World Health Organization that they have just published this year in order to promote cardiac rehab programs across the globe with the minimal things that you need to create a cardiac rehab program. Mm-hmm. So I think that we need to work on increasing the awareness about cardiac rehab.
Erica, did you want to?
Yeah, Marta, sharing that remind me of a trial we did early on with physical activity intervention with a wearable, and we became, in essence, cardiac rehab educators because we were going to the bedside to enroll people in the study, and many of them didn't even know what cardiac rehab was. And so we were trying to get people to participate in the study, but there was a position at one point where there was a nurse and that position had been eliminated. And so it just brought about, there's this huge gap in even just education and awareness of the patient. And then once we told them, here are the benefits, here's what this is, then they were super excited and wanted to participate. So a lot of opportunity.
Yeah, that patient education piece up front is a really critical piece. It's not just placing the order in the electronic health record, but also getting someone to really understand what it's about and it's important, and the endorsement from the clinical team as well as understanding what it is. Well, let's move on a little bit. Let's assume that we've done a good job. We used the EHR order. We educated the patient. They're actually going to go to cardiac rehab. Let's talk a bit about what this looks like if we're doing a digital home-based approach. And again, Jesse did a nice job outlining kind of what some of the landscape is and the tools that can be used. But let's talk some about what digital cardiac rehab really can look like. And maybe we can compare and contrast the U.S. and Spain a bit. Dan, you all are doing quite a unique program in Pittsburgh as part of our PCORI grant and maybe outside that as well. Do you want to talk a bit about what, in your mind, what home-based digital cardiac rehab can look like?
Yeah. Again, I'm going to dwell on the perspective that I bring, particularly thinking about older adults and the challenges of physical frailties and sarcopenia and risks. So in thinking about home-based models, we're really trying to emphasize the transition from hospital to home. So one thing which I think stands out is when the option for digital strategies is on the table, it does facilitate more rapid uptake of cardiac rehab, whereas traditional site-based models usually entail a discharge and then a referral and then accessing the program, and there's a series of delays and impediments which I think for many patients, particularly older patients, but really any patient, are very hard. It just gets compounded by age, by access, and all the limitations of someone who's older. So in Pittsburgh, we've been trying to think about models that really enable an older person to start cardiac rehab at home in a way that's more actionable. We've had, even before this PCORI project that you're mentioning, we focused on transitional care, having a transition model where there's a coach that actually helps the participant or the patient to really know about cardiac rehab, know about different models, and to really facilitate knowing the options that are where site-based is located and what are the alternatives to a home-based model, and to really understand what that means and how to do it. So I think, and there's a good deal of literature to talk about the utility of coaching for patients that might not have the facility to just pick up the ideas of the concepts so readily. So I think coaches are really important. In this PCORI project, we're in a randomized way looking at site-based versus home-based models, you know, with digital health enhancements. But we've looked particularly at ways to facilitate home-based models that seem relatively safer to participants. We've talked about using a device that where participants have the ability to start exercising from a seated position with incremental increases of frequency and intensity in ways that feel comfortable and really are a little bit more conceptually appealing to them. So again, I just keep emphasizing the fact that for most people that are hospitalized, that are dealing with the disability of hospitalization itself, compounded by new medications, compounded by multimorbidity, cancer, and many other morbidities, starting exercise at home can be hard, but it is achievable, I think, if you take the steps with coaching, with added care, with using the family, using other patients that are perhaps in a buddy system, really trying to help patients overcome some of the initial sense. And it's much better than not exercising at all, which is really the most common scenario for the vast majority of patients, which is really a certainty towards progressive disability and premature death and nursing home placement.
Yeah, so I like that you brought up the coaching as well as, you know, buddy system, patients, for the patients and their families. Anna, I wonder if you and other panelists could kind of comment on this social aspect, this human aspect. We're talking a lot about the technology, digital technology, and we can get, you know, folks to exercise at home and monitor that. We can also support risk factor modification. But one of the kind of core features of in-center cardiac rehab is that social cohesiveness between patients and the staff. And how do we, I wonder if we could think through as a panel, how do we really make sure we reproduce that or even augment that in digital cardiac rehab? I think in Jesse's slides, she really touched on that a bit, how you know, we can possibly have even greater caregiver and social support integration if we use technology, the virtual platform, in the right way. So how do we make sure we kind of honor that tradition of in-center cardiac rehab and maybe even augment it in certain ways? Start with you, Anna, but also welcome other panelists.
No, that's an excellent point, and we had a number of discussions. You know, we started with what are the perils of digital health? Are they going to, is it going to make the barriers larger? And we talked about that. And the second component, social isolation, is a huge issue, particularly when we talk about multi-morbidity and older. So those are the patients who are most likely not to be able to come, and is the home solution, like, is the digital solution make it more intrusive? So we put forward that it absolutely has to enhance and it has to have that as a design, as part of how are people going to get together and then work through the technology. Because in one way we are asking for more personalized approach, and then I have to draw from the oncology side because those are the patients that I see, and I often utilize, depending on how large the cancer center is, in centers, they've realized that, so survivorship groups that are supported by the navigators, and just recognizing that there is a connection between the need for the psychosocial support, the need for exercise support, and the need for diet support, on bringing that together. It's so that through that kind of model, I always feel that, so I try to link my patients to both the cancer survivorship with those tools and to cardiac rehab, and there are a lot of similarities. So I think I would envision, even for the cancer survivorship programs, to borrow from cardiac rehab and to have the CrossFit in trying to find common solutions.
Did anybody else want to weigh in on?
I mean, in Spain, we usually work with social workers. So this is like a healthcare professional that study the situation of the patient, and then in Spain at least there are some money that the patient can get from the government when they have a difficult situation, for example, that they don't can pay, they can pay the medication, or for example, if they need a caregiver. So the government, there's some money from the government to help with this kind of patient at home.
Great.
I think that this has been looked at in other patient populations, but this idea of gamification and, looking at psychology of people that are intrinsically motivated versus extrinsically motivated. And so if people are never going to go into an inpatient cardiac rehab center, they're going to start virtually and they're going to stay that way. There's an opportunity to match individuals in a virtual world and have them be connected that way and monitor their goals, almost in a sense, compete with each other, but also motivate each other to achieve those goals. So I think that there are some possibilities, and people have looked at this in other patient populations, and we should learn from that and see if that works for us.
Absolutely.
See, the other thing is somehow we have been discussing whether center-based cardiac rehab is better than home-based cardiac rehab. But the reality is that perhaps the best solution would be not having a divide. Some patients might perhaps do very well coming to the center once a month and doing everything else at home. Other people might actually do much better coming 3 times a week. They may live very close to the center, whereas others might completely be unable to come back, right? So I think that is something that we need to be very flexible to design systems that are adapted to patients' needs, preferences, and the logistics, right? The second thing is that we should also be careful not to assume that older individuals, just because they are older and with some cognitive decline perhaps, are unable to use technology. It has been shown during the COVID pandemic that actually people over the age of 65 or 70 were heavy users of technology, especially Facebook and even Zoom. And the reason was because that was the only way for grandpas and grandmoms to see the children, right? So the motivation to do that was a big driver to learn how to use those things. And therefore we cannot just assume, but it's important to recognize that in the design of the devices and tools and programs, it has to be, people need to be mindful of that issue.
Right. Are any of you using Facebook support groups as part of your cardiac rehab? No. But I want to amplify your point about hybrid cardiac rehab, that this can be very much tailored to the individual, whether it's somebody who's going to come in and maybe do half and half in-person, home, someone who's just going to do a little bit of in-center up front and then go fully home-based versus someone that does mostly in-center. It's very much tailored. It's kind of like a continuum in a way, that combination of in-center and home-based. And we need to be, as you said, the word flexible, really well said.
I do want to highlight, you've already referred to this, but I want to emphasize that the flexibility really is important. And it's easier said than done. I want to, the elephant in the room is the finances of that. And the fact that many hospitals that have existing site-based programs are reluctant to talk about, in a sense, cannibalizing their population, as they might see it, to having home-based models that compete. To me, and I keep trumpeting demographics, the vast majority of older people don't go to cardiac rehab at all. Frankly, the underuse of cardiac rehab is notorious for every population. And it's only growing worse as we talk about heart failure and other indications. These populations do not use cardiac rehabilitation. So the notion, it's essential, as I see it, to expand the model. And the fact is that patients frequently like to come to the hospital when they happen to be able to be at the hospital, but they don't like coming 2 or 3 times a week because the logistics of getting there, of parking, of time, I mean, there's just so many barriers. So I think having flexibility, letting people feel like they can come when they're able to do so, having the resources to exercise at home in a way that feels safe and supported, I mean, that's a win-win proposition, but we're now taking the steps to get there.
Yeah. So, well, you brought up the finances and sustainability, and I did want to make sure we weaved in some of the additional legislation in the works around off-campus facility reimbursement and telehealth reimbursement, which is something that was prominent during the pandemic, and we're hoping will be a long-term, available long-term to support cardiac rehab programs. Francisco, do you care to comment on
Yeah,
this addition?
well, and that is perhaps the most important legislation and potentially the most impactful legislation that might pass in this coming session, because the bill is about paying for home-based cardiac rehabilitation. And we know that in medicine, what is not being paid for doesn't happen. And is so essential, because without the funds, we will not get anywhere. So this is one of those areas where we usually don't think about, but it's important to be mindful and to do advocacy and either state-based, society-based, etc. AHA is doing some things, ACC is doing other things, but the rehabilitation world we should also do our part. So that's one. The second thing is that we need to prove more and more the cost effectiveness of the use of of new technology to deliver and to scale cardiac rehabilitation that very likely will end up being cheaper. And that's very important, because if you happen to get the same clinical benefit at a lower cost, it's going to be more likely to be paid for. And I just remind the public that somehow high-tech or areas of cardiology that rely a lot in high-tech, I mean high-tech being very expensive devices and things, generally get paid for, okay? So it's not a matter of being cheap or not. It's mostly about the lobbying efforts to get those bills passed, and that's something that it might be so determinant for the future of cardiac rehabilitation in the USA. However, even countries that get global coverage for everyone, they struggle to get everybody participating. And some countries like Canada that has socialized medicine, even them somehow don't get paid for home-based cardiac rehabilitation. So it seems like the solution is not that simple, but at least, for what pertains to the USA,
Right.
I think we have a lot of work to do.
Yeah, for sure. And you're bringing up the international perspective. So let's bring it to Marta now, to where they have a public health system. I'd like to get your perspective on what you feel are kind of the advantages or the weaknesses of your system versus what you've seen in the U.S.
So one of the strengths is that is the accessibility. I mean because it's free for everyone, but the weakness is the lack of resources. So this is the main thing. And despite all the evidence, we don't get all the patients that we should get in the cardiac rehabilitation program, and we are starting to do the hybrid program, because one of the things that we want to get is that the patients get back to work as soon as possible, because it's a money issue too for the country. So I think that this kind of tools will be very useful to get that. So but the resources are the main weakness of the public health system in order to implement digital tools and so on.
Understood. Do you want to speak just a little bit more about kind of what resources you have from a technology, and also just sort of the team, who's available in cardiac rehab, the exercise physiologists, other team members to serve the patients, and then maybe Erica, you could share a bit more about the U.S. perspective in contrast. Yeah.
So in Spain, we don't have exercise physiologists, so we work usually with physiotherapists. And in our team, we are the cardiologists, physical medicine and rehab, nurses, the PT, psychologist, and now a social worker. So this is the team that we have in our hospital. It's different in every hospital. It depends on the resources, or human resources. I think, one of the strengths here is that you have the exercise physiologists, that the education is better, that compared to the PT, that they usually don't learn that much about cardiovascular things and so on. They are used to treat musculoskeletal stuff, so
Very impressive. They have a staff of 10 people, and they see 500 patients a year. So I told her, we need to visit you to learn some efficiencies.
Right.
We don't do that good.
Right. Yeah, I mean, she's talking about the low resources, but sounds like a great team, and you're serving a lot of patients. Erica, can you speak a bit about what, in your experience in the U.S., what things
Well,
look like?
Yeah, I mean, I say it's similar to the way that Marta described it, but with the addition of an exercise physiologist. And
Yeah.
there are advantages that come with that, right? I do think that there are some patient safety issues. I think that patients feel more comfortable when that person's there. And there's just a different perspective that person brings and a patient education that they can provide. And speaking back to what Francisco said, I do think that there is this reluctance because people are really focused on the upfront cost of doing this, and there does need to be more focus on in the long term. I experienced this when we were developing an app. It is very expensive to begin with, and it's very time consuming. And in the long run, these types of solutions are more scalable and they are more cost effective than the current system that's in place.
Great. Yeah, that's a key point. I mean, the cost is going to drive things, and there is the potential to save a lot of money from reduced hospitalizations, so forth. Anna, do you want to elaborate on sort of some of these additional benefits that you see in terms of scalability of digital cardiac rehab and the cost side of things?
I do, and I feel it's always the going back to square one. How is it scalable and sustainable, right? We have it feels that we really need as we continue to advocate, and these are small wins, but I think from the legislation perspective, I think hopefully they will lead to what really is sort of value-based care. And I do think that the healthcare organizations are very slowly but still moving in the direction where somebody would look and say, well, it is more cost effective for this system to invest and to incentivize cardiac rehab teams so that the outcomes are better. And they could, with that could come ask for the outcomes, but then it's really because right now, just like you pointed out, it's seen, okay, well, we get the reimbursed for X and that's the payment. And that's really still the main sort of like value. But the moment that the healthcare system starts moving towards, there's always going to be investment in the payment right up front. But then when that outcome is seen, that the patients do better and the teams, I think that's the only solution, I think, to these really deep problems.
Let me just emphasize the point. We're doing better with survival overall in every other aspect of cardiology. So people will live longer. So the notion of value, I think, really has to be seen in that with that lens. You will live longer with perhaps progressive disability unless you emphasize the vitalization of cardiac rehabilitation, the exercise, the focus on wellness, risk factor modification. It becomes more valuable because people are surviving. If everyone passed away at 50 years old, this would not be an issue. You'd treat the disease and do the best you can. But people are living into their 80s and 90s, and so these years of relative infirmity are very expensive.
I have one more thought that just came particularly at this conference because there's so much emphasis. I feel that we are seeing a little bit of revival of prevention with the new drugs, and it's interesting how people get really excited about the drug that can lead to weight loss and all of these things. And we were just talking with Alexis before. If you want to measure just a very simple measure, take your patients and check how 6-minute walk before and after cardiac rehab, you get a lot of people who actually do it. If you get the things, you will get the outcomes the equivalent to many of the drugs that are because immediately, okay, who's going to pay for this? How are we going to scale? So here so what I'm saying is as a cardiology community, in the cardiovascular community, we started moving that towards the value and emphasizing prevention. I feel it's key to embed the exercise and core principles of cardiac rehab, which started with secondary prevention because that's we first saw it as a core of that. So because it really delivers and sort of to use the momentum of the focus of prevention to change that money proposition, if you will, that is about long-term outcome. It might be naive, but I still believe it.
All right. Well, thank you. We're up just a little bit of less than a minute left, so I'm going to close things out. I want to first of all, big round of applause for our panelists. Thank you to all of you for sticking around on a Monday afternoon. We have a little bit left. We still have an innovation showcase, so stick with us. And we're going to move on now to our first innovation showcase presenter. So thank you again, panel.
Hi, everybody. My name is Jendrik Wosik. I'll just take about 4 minutes of your time. So I'm a cardiologist at Duke. I've got a rural cardiology clinic. I'm also the medical director at my local cardiac rehab program. But I recently joined Samsung Health to lead their heart health initiatives. And so I'm presenting HeartWise, a development that was done with Kaiser Permanente and Samsung Health around cardiac rehab and digital cardiac rehab. Just kind of a comment of how Samsung approached this and why they decided on pursuing cardiac rehab. There was this identification of a need that they identified. Many have spoken about this already in terms of the impact of cardiac rehab, that compared to other therapies, how impactful cardiac rehab can be compared to even antiplatelets or beta blockers. But we also know that it's extremely underutilized, and this has been spoken about before and published and so again, many in the audience have published on this and speak about this, but 29% do cardiac rehab, not many complete. So again, Samsung thought, how can we help both with referrals, both with engagement, both with completion? But the needs and the challenges had to be identified. And so, for example, referrals, missed opportunities to refer. How do you refer? And so that's where this co-innovation with a partner like Kaiser was initially proposed. Capacity constraints. There are not many cardiac rehab facilities, long possible wait times, but really expensive and inconvenient sometimes for certain individuals. Co-pays. I know my patients sometimes have co-pays. And some don't have travel. So again, virtual home-based cardiac rehab is an option. And then equity really was another piece of this, where Samsung thought, how can we approach this to provide everyone access to this? And so this is, again, another slide about just the digital divide. It still exists, but it's improving perhaps. So smartphone ownership across all ages. And so again, my patient population, the average age is around 75 or so in my clinic. So I'm pleased to say that many bring smartphones to my practice. And then 21% of Americans are reported to own smartphones or fitness trackers and smart watches. So again, those red arrows are those underrepresented groups in cardiac rehab as well as other therapies that are owning some devices. So there is opportunities. And so that's where Samsung and Kaiser worked together to develop a smart watch-based cardiac rehab program where the watch helps the individual exercise. There's a mobile application that's device agnostic, whether Android or iOS. And then a clinician portal, so that a platform, as they call it, meaning with a watch, a mobile app, and a clinician platform. And so yeah, sorry for those are, yeah. And this is a close-up of some of the experiences in terms of what the patient is experiencing on their smartwatch. They're given this smartwatch, and they're asked to return it at the end of their 12-week time. But again, focus on large text, easy buttons, easy to use to make sure that it's accessible for as many people as possible. So before exercise, during exercise, symptom management, reporting, exertion descriptions, and then some encouragement. And so really the watch is this centerpiece of this cardiac rehab program. But the mobile app is also there, where it's interpreting information, storing information, showing information, even helping with medication management. And then this is really the journey that it's together with that referral partner, identifying the patient. They're referring the patient into a home-based virtual program, educating them on the devices, and then monitoring their progress, and then than finishing up and having the devices be returned. It's been clinically proven with Kaiser, with over 16,000 patients, many visits, good outcomes in terms of readmissions, and then this impressive 87% completion rate for this specific program. So again, impressive results, and it's great to see this completion rate. And the group has published in JAMA Network and other about their experiences over the years. And so kind of in my last few seconds is where is Samsung headed next is hopefully with you all. So that's why they hired me to lead their heart health initiative. So I look forward to collaborations and working with you all on kind of the next iterations and the futures of what Samsung Health will bring. And parts of these are algorithms, partnerships, and then value propositions, because we know that this value proposition is necessary to keep it sustainable. So thank you all for your time, and amazing group here. Thank you.
Do we need to stand up? Anyone? Get a stretch? We're all good? Okay. See some stretching in the back. So I'm a cardiologist from UT Medical School in the Texas Medical Center. And at heart, I'm a cardiologist really looking for unmet needs. I'm looking for technology companies that are willing to go down a journey and figure out those unmet needs in a scientific and academic fashion. Willing to do the necessary studies that we need to publish so that we can all work together and get these approved by CMS and Congress and all the necessary things that we need to do to make cardiac rehab a ongoing reality, especially in the remote sense. One of those companies named Cardio, who was in the remote patient monitoring and chronic care management space, brought me on board, and after a very compelling discussion on population health and unmet needs in the cardiovascular space, was able to really convince them that we need to focus actually moving from just the RPM and CCM space into digital cardiac rehab. Okay, so next slide. Okay. So I think we already know what the problem is, which is from the Million Heart Lives and from all the panel discussion here, which is this, and I think we've already kind of reiterated this many times, that underutilization. And I'm from Texas, so if we can go back one. Yeah. I can't talk that fast. I can talk fast, but not that fast. As they're getting that together, I mean, we already know that, very difficult for patients to come in for 36 sessions, to go to a bricks and mortar, and it gets actually worse when we look at female representation and also other ethnicities. So one more. I think we belabored that point. Let's go to the next slide. But in Texas, as I was saying, I'm from Houston. So we know in phase one, very easy, PTOT comes after post-TAVR, post-MI, even indications for heart failure or other operations with mitral valves. But look at the huge drop-off in Texas. I mean, in the nation, it may be 20% in Texas. So borrowing from NASA, Houston, we have a problem. But in cardiac rehab, it's a global problem. So it's not just isolated to the U.S. Next slide. Okay, so I mean, I think the panel went over very well today about physicians' barriers to cardiac rehab and patients' barriers, all the socioeconomics. So we can go to the next slide. All right, and so what's the American Heart Association stance? Because some of the feedback that I get from physicians is, is this going to be safe for my patient to do this at home? And I think that's been very well delineated, even by studies. And American Heart said, as a statement, and this, I was at AACVPR, where they talked about digital cardiac rehab, in fact, is safe, that it is effective. And of course, it's the barriers that we're trying to get that adoption rate up. And so doing this at home base is possible and is also very safe. And so the HA on improving cardiac rehab made a statement that we really have strong evidence on the benefits across many cardiovascular conditions. And those patients that actually go through cardiac rehab are better supported, improving their behavioral changes, and optimizing their cardiovascular health and sustaining those behaviors. And I'd add, one more layer that with the digital health that we're actually utilizing, it's also the care pathways that the HA has made to integrate and make sure that we're really practicing at a level of evidence. Next slide. So what is the digital solution? Well, the digital tech can support the expansion by reaching patients on their terms when and where they want the delivery of their care. And that's via these digital platforms and combining digital modeling, data acquisition with the HA care pathways for the education that we talked about really does help support with better adoption and adherence with the aim to improve cardiovascular health, keeping in mind all of the topics that we just talked about in health equity. Next slide. And I think we went over this slide earlier, but it is this combination of synchronous, asynchronous, creating those digital platforms and making sure that we were able to transmit to the patients and also receive from the patients and give out those behavioral changes through these pathways that we've talked about. Next slide. And really the conclusion is that we have a Class 1A indication for cardiac rehab. I mean, it's amazing. This is not a 2B. This is a Class 1A, and we've proven through the research from the AHA and AACVPR that it is a low risk, and that we can prevent secondary cardiovascular risk. But we have this issue of underutilization. The digital tech can bridge the gap, bringing bricks and mortar CR to the home, and working with cardio. Its membership with the American Heart Association Innovators Network has the digital technology to make cardiac rehab a reality. One of the differentiators I think that cardio is doing is not only they do vital acquisition, but they actually have a real-time remote heart monitor that brings what is the standard of care in a bricks and mortar to home. We have to have all of the assets of bricks and mortar to make this a reality, to bring it into the home system. Thank you so much.
All right, excellent. Well, while they're pulling my slides up, I just have to say what an esteemed discussion and panel. I just really enjoyed the global perspective and just all the experts here sharing their opinion. So thank you, and also great to see some of the demos here. And that we still have a crowd at this hour, I'm flattered. Okay, great. So let's go through this and really make it patient-centric. I know many of us clinically have taken care of patients like Andy. He's 52, he's a flight attendant, and had a heart attack and was referred to cardiac rehab. So he passed the first test in getting referred to cardiac rehab, that's great. But he has a busy schedule. It was really just unfavorable for him to come into downtown Baltimore to engage in activities. And honestly, the cost of parking is about $12 by the time you finish a session, and copay was quite expensive. And so we thought, how could we re-engineer this and give him an opportunity to get the benefits of cardiac rehab, but meet him where he's at and provide him with all those core principles, but at home. And so we created the Corey Health solution and tailored it around a smartphone application delivering the key principles of cardiac rehab, which I'll walk through in more detail. A smart watch paired with the application, as well as a blood pressure monitor. We also provide resistance bands so they can do stretching and exercises, and a pill box to keep them on check with their medications for the week. This all pairs back with a clinician dashboard, and we have an exercise physiologist who does virtual remote coaching sessions focused in on what that patient's needs are, very flexible, adaptable, and personalized. Similarly to the presentation that was earlier, we have a 12-week timeline. We're really focusing on enrolling our patients, getting them engaged, why this matters, why they need to have improvement in their cardiovascular health. And while they're getting that opportunity to get the technology onboarded, they're feeling comfortable, we do have them engage in a hybrid program, which means they do 1 to 2 sessions of inpatient cardiac or center-based cardiac rehab to get their feet wet with cardiac rehab, to have an opportunity to work with an exercise physiologist and make sure, like we were talking about before, it's not a one-size-fits-all. We want to encourage them to participate in inpatient as well, or the outpatient cardiac rehab. And then once they're working through the program, so once a week, they're interacting with our health coach in a virtual capacity, but they're also working with Corey on a daily basis, being reminded about their exercise activities, keeping up with their medications, checking their vitals, and watching really engaging videos to help educate them. And I'll be giving you a glimpse of that as we move to the demo. The other thing is that we like to give them positive reinforcement. I know a lot of times when it becomes a behavioral intervention, we might tip towards, giving more, oh, you shouldn't do this, you shouldn't. But what we try to do is celebrate the victories, bring the wins to the patient, and really acknowledge that they're trying their best, and we're happy that they completed their exercise goal. We're excited that they took their medications as prescribed. And ultimately, graduation day is a celebration. It's not just completion of the 12-week program and have a nice life. It's giving them that skill set so that they can continue this for a lifetime. Now let's get started and learn a little bit more about Corey with a deep dive demo here. The first step is medications. This is critical. A lot of our patients have had MIs. They're on dual antiplatelet therapy. Every day we want them to follow up. Are they taking their statin? Are they taking their Plavix? Or are they taking their aspirin? Then we want to make sure, are they checking with their vitals? So not just are they checking, but are they doing it the right way? So here's a tutorial where they check their blood pressure. And then, of course, exercise and activity. We have them enter in their vital signs to make sure they're in the safe zone before they proceed with exercise. We also have them check off whether they have any symptoms. And if they don't, we're ready to proceed to their exercise activity. They begin exercise, and here we track their heart rate, their steps, as well as their overall goals. When they're done, even they can rate their perceived exertion. Were they really pushing it hard or taking it easy that day? And when you flip it around to the clinician side, we have a heat map here where you can see if patients had been adherent to their medications. Then as you flip to vitals, you can see the trends. Are they generally in that less than 130/80? How about their heart rate? Are they generally in the 70s, 60s as we want them to be? And then what about steps? Are they taking it too easy? Do we need to coach them to get a little more vigorous? Here's an example where Mansi might have said, turn up the heat, okay? So they're walking more, they're exercising, they're doing elliptical. And then as you can see here, we get deep data on how they're doing during each of their exercise activities. Now, we need to go into the core risk factor modification. Here's an example of lipid management. We put a patient on Crestor after an MI, for example. Then we're adding on a PCSK9 inhibitor. They're tracking their evolocumab and their rosuvastatin on a daily basis, maybe every 14 days for the PCSK9. They're entering in their bad cholesterol, and they see where are they on the scale. Great, they're at goal less than 55. They can also see their history. Now as we go to education, it does have audio, which might not be coming up, but not to be a spoiler alert, this is a lipid educational video that is narrated by none other than the world expert, Dr. Seth Martin. So you're going to have to reach out to me if you want to get the full narrated video, but I'll just let your imagination run with it. But what I want to highlight here is that Dr. Martin's really taking them through what are the simple ways to understand what cholesterol is. Why do we want the number to be less than 70 or less than 55? Is statin the only med that's there? The answer is no. Ezetimibe, bempedoic acid, PCSK9 inhibitor. And we end it all with connecting them with people just like them through Facebook with a social network that's private, that gets them connected with the community. So we're really excited about what we're doing with Corey Health, how we're working with Corey, incredible collaborators and all of you, and all the programs that are out there trying to solve this solution. But I wanted to highlight one thing which our panel had a beautiful discussion on. health equity, this is an opportunity for us to make a difference, both in the way that we're providing technology to those that have it, but also providing an iShare program, which is a loaner program where we allow and provide technology to those that don't. And so when we think about these programs and reaching everyone, we need to think about reaching everyone creatively, even for those that might not have a smartphone or might not have a wearable. The other thing is that from the start to finish, our patients are involved in the process. From the moment, as Francisco mentioned, conceptualization to implementation, we need to be right there with our patients, understanding their experience, what they want, what they don't want, and implement it in our tool. And that's been a core mission of ours since the beginning of this journey, and I'm very proud of it. I just want to highlight that our goal and our mission at the American Heart Association, at all of our individual institutions, is to not just reach a few patients, but it's really to reach all of our patients. And the story with Andy was a story of how we made that happen and how we're going to make that happen for more people. Together, all of us, as a united force in the US and globally, we're going to make it happen. Thank you.
All right, and so now I'm going to round it out. You've heard, I think, a number of different ways today that people are delivering and thinking about using digital tools for cardiac rehab. And so one of the things that I'm interested in is this field called implementation science, which is basically like once you have an effective or efficacious intervention, how do you actually get a lot of people to start using this and implementing it? And so we have a study, it's called the McNair study, which is studying the comparative effectiveness of in-person and telehealth cardiac rehabilitation by implementing that at 4 sites. Here are my disclosures, which includes that I received this grant funding from PCORI for this project. So the first thing I want to talk about is that this is a patient-centered study. And so we have a patient advisory board that we work with for this study. And we went to the patient advisory board and we asked them, what should we call the study? I was fully prepared to use cardiology naming conventions and come up with like a cool acronym for the name of the study. And the patients said, no, we want to name the study after one of the patients. And so we voted on it, and we named the study the McNair study after one of the patients who's on our patient advisory board. And I asked her, I was like, Trisha, are you okay with us naming the study after you? Because we're going to be saying your name a lot. And she says, you know what, at first I was a little bit uncomfortable about it, but I want to give my name to this study so that I can represent all of the women and the people of color who don't get to go to cardiac rehab. And we're hoping that by providing people with more options that we can improve the accessibility of cardiac rehab. And so we have the McNair study. And thankfully I can pick the letters MCNAIR out of comparative effectiveness of in-person and cardiac telehealth cardiac rehab too, so I still get to do a cardiology allowable acronym. So the aims of this study are both implementation and efficacy aims. So we're going to be looking both at things that are related to the implementation of telehealth cardiac rehab at 4 sites, but also to the efficacy of the program. So the first aim is to tailor a telehealth cardiac rehab program to diverse populations at 4 sites. And so at each of these 4 sites, we're going through human-centered design sessions so that we can understand the needs of the diverse participants in our communities and tailor a set of cardiac rehab tools for delivering telehealth cardiac rehab to those individuals. And then the second aim is a randomized controlled trial comparing outcomes between patients randomized to telehealth cardiac rehab and patients randomized to in-person cardiac rehab at each of these sites. Our primary outcome is exercise capacity measured by 6-minute walk distance at 12 months. And then the third aim is to understand some of the implementation-related factors, including patient perceived costs. So the costs experienced by the patient that are influencing the implementation of and participation in cardiac rehab. And so here's our timeline. So here's where we are. We're just finishing up our AIM-1 tailoring. And I'm proud to say that as of today, we've enrolled 2 people in our AIM-2 randomized trial. So you'll notice that that arrow is very much at the beginning of that whole process. But hopefully in the next couple of years, we'll be telling you about the results of this study. And so some of the quotes that I've pulled from our AIM-1 work, and this is all news for everybody in the audience. You may have seen these. These may come from your people. In terms of like thinking about telehealth and in person, you know, there are some people who have definite preferences one way or the other. Some people say, you know, it was really hard to do in-person cardiac rehab, and so the ability to have a telehealth option was really important for me. Some people are just reflecting on how the pandemic has really changed the way that they think about this, and they may not have been open to it in the past, but now they are open to something like this. And, you know, some people, I don't mind the Zoom, but, you know, I like getting hands-on in the gym. I think there's a couple of other important things that are coming out in here. One is that people still matter. So even though we're doing digital cardiac rehab, we're still very much envisioning this as a thing where there's actually a human coach, a human person who is helping the cardiac rehab patients through this journey. But with telehealth approaches, people feel like people go home with them, which can help them in that transition period to making lifelong change outside of the cardiac rehab gym. And then I think everybody has to recognize that there is some element of figuring it out. You know, some of that's just, you know, figuring out how to put your computer in a place where people can maybe see you exercising. But some of it is coming up with the right training and tools to help people use the technology. So a lot of the work that we're doing, we're making available in a thing that we call the Cardiac Rehab Toolkit. And so you can go to our website. I put a QR code up if anyone wants to take that. And so we have tools that are kind of templates that we've created, or there are scripts and various other things. And then we're also trying to catalog the variations that people will see at different sites as we modify these instruments to be able to deliver cardiac rehab to our diverse populations. And so this will be updated as we continue through the study. And I'd just like to thank everybody, including all of our clinical sites and partners. And do you want to give a closing, Pat, or shall I? So, you know, I've been doing this for like a decade now to try to get people into using digital tools for cardiac rehab. I'm thrilled to see so many people here, and I'd like to proselytize all of you and bring you on board. So if you ever want to talk about digital cardiac rehab, you can talk to me or any of the panelists or anyone. It's a great community, great people. So, and I'm really excited that we had this great session today. So thanks to everybody who participated and to our audience for being here.